Bismillahirrahmanirrahim. Assalamu alaikum everyone. I'm Dr. Abdul Hakim, urology resident, presenting the treatment of UTI, the series of previous lectures on urinary tract infections. Learning objectives. We will briefly discuss about the antibiotics commonly used in urology, source control before starting the antibiotics, and management of sepsis. Goal of treatment of infections. Goal is to eradicate the offending organisms by selecting appropriate antibiotics. Common pathogens of UTI. UTI most commonly caused by gram-negative bacteria, and 80% cases are caused by the E. coli. Other important gram-negative bacteria are Proteus, Klebsiella, Pseudomonas, and gram-positive bacteria are less common. These are Staphylococcus saprophyticus, Mycoplasma, Chlamydia trachomatis, and Neisseria gonorrhoeae. Selection of antibiotic depends upon certain factors. These are infective pathogens, patient-related factors, and site of infection. Antibiotic sensitivity to organism, single versus polymicrobes, and pathogen versus normal flora. And normal flora, we don't have to treat the normal flora. Community versus hospital-acquired infections. The patient-related factors are hypersensitivity reactions to antibiotics, any comorbid conditions such as diabetes or renal failure, current medication, age, previous antibiotic therapy, pregnancy, lactation, and patient either admitted or outpatient. And site of infection, either the infection of the kidney, bladder, or prostate. Commonly used antibiotics are penicillin, cephalosporins, nitrofurantoin, phosphomycin, vancomycin, timoxazole. We will briefly discuss one by one. Sulfonamides. Sulfonamides include a trimethoprim, sulfamethoxazole. These inhibit the synthesis of tetrahydrofolic acid that is necessary for the DNA synthesis. These are bacteriostatic drugs and cover both gram-positive and gram-negative bacteria. And the major side effect of these antibiotics are hemolytic anemia in patients with G6PD deficiency. And these are contraindicated in folic acid deficiency state and in pregnant patients. Usual dose is 4/200 or 80/400, 2 tablets twice daily, or 160/800, 1 tablet twice daily.
Trimethoprim sulfamethoxazole initially it was the first choice of drug for uncomplicated infection, but because of emergent resistance, now the guidelines has changed, which we will discuss later.
Fluoroquinolones. Fluoroquinolone, we mostly use the ciprofloxacin and levofloxacin. These inhibit the DNA gyrase and inhibit the bacterial DNA synthesis. The use with the antacid, iron, zinc, or sulfate decrease the oral absorption of fluoroquinolones. These can be given oral as well as through intravenous route. These are broad spectrum antibiotics, cover both gram-negative and gram-positive organisms. The major side effects are dizziness, seizure, confusion, and tendon ruptures. And these should be avoided in pregnancy. The usual dose is 250 mg or 500 mg twice daily. And levofloxacin usually given 250, 500, or 750 mg once daily. Nitrofurantoin. Nitrofurantoin are bacteriostatic antibiotics, and these cover usually gram-negative organisms. And these should never use in treating the infections such as pyelonephritis or prostatitis because of poor tissue penetration. The major side effects include the pulmonary fibrosis, hemolytic anemia. These are contraindicated in renal impairment, the patient in which creatinine clearance is less than 50 ml per minute. And these should not be given in third trimester of pregnancy because these causes hemolytic anemia in the fetus. The dose is 50 or 100 mg 6 hourly.
Now the nitrofurantoin is the drug of choice for uncomplicated UTIs, and it can only be given in uncomplicated. In complicated and septic patient, we should not give nitrofurantoin, as it mentioned that it has poor tissue penetration.
Aminoglycosides, the mostly used in the treatment of UTI are amikacin, gentamicin. These inhibit the bacterial protein synthesis and excreted in the urine by glomerular filtration. These usually cover gram-negative organisms, and major side effects are ototoxicity and nephrotoxicity. And these also should be avoided in pregnant patients. And renal dose adjustment is required in the patient of renal failure. The dose is 500 mg per 2 ml are 15 mg per kg per day. Cephalosporins have 4 generations, and we usually use the second and third generations. These inhibit the both gram positive as well as gram negative organisms. Penicillins, these inhibit the bacterial cell wall synthesis by irreversible binding of beta-lactam ring to the bacterial enzyme. Aminopenicillin usually cover enterococci, staphylococci, E. coli, and proteus, and piperacillin, such as tazocin, usually cover the Pseudomonas. Side effects measure the hypersensitivity reaction, and these antibiotic decrease the platelet aggregation. These include the augmentin or tazocin. Augmentin is usually given 625 mg 3 times daily or 1 gram twice daily, and tazocin 4.5 gram 3 times daily. Phosphomycin inhibit the bacterial cell wall synthesis, and majority of these cover the majority of the gram negative organisms and vancomycin resistant enterococcus. And these antibiotics are excellent option for multi-drug resistant bacteria. Usual side effects are GI upset and vaginitis. And in uncomplicated infection, the single dose of usually phosphomycin 3 gram is given, and complicated infection phosphomycin is given every 72 hourly. Glycopeptides, for example, vancomycin, these inhibit the bacterial cell wall synthesis and effective against the all gram positive organism, especially the methicillin resistant Staph aureus. Side effects include the ototoxicity, fever, phlebitis, and nephrotoxicity. The dose is 500 mg 6 hourly or 1 gram twice daily. An ideal class of drug for the treatment of uncomplicated symptomatic UTI in women is aminopenicillin, option B, aminoglycosides, nitrofurantoin, or cephalosporins.
Anyone in the audience?
Dr. Adil, antibiotics that require adjustment in renal diseases. These include the aminoglycoside, piperacillin, vancomycin, tetracycline, and sulfonamides. The drug thought to be safe in any phase of the pregnancy. Option A, fluoroquinolones, B, nitrofurantoin, C, penicillin, and D, sulfonamides. These are the antibiotics that are safe during pregnancy are penicillin derivatives, cephalosporins, beta-lactamase inhibitors. Nitrofurantoin is safe in first and second trimester, but should not be given during the third trimester because it causes hemolysis. And phosphomycin is also safe. The antibiotics that are contraindicated during pregnancy are tetracycline because these are teratogenic and causes staining of the teeth. Trimethoprim sulfamethoxazole causes neural tube defect. Sulfonamides and aminoglycosides. Source control. Before start of the antimicrobials, the source of infection should be eliminated. For example, if abscess, perinephric abscess should be drained, and any obstruction due to any cause, stone or any other cause, should be relieved, and wounds should be debrided. If persistent growth of urease producing bacteria, for example, proteus is detected, then stone formation must be excluded. And in men, digital rectal examination has to be performed to investigate the possibility of the prostatic disease. So define asymptomatic bacteriuria. Asymptomatic bacteriuria. कितना मतलब बैक्टीरिया कितनी क्वांटिटी होनी चाहिए?
Is there any difference in male and female? Yes.
Midstream sample of urine showing the bacterial growth more than 100,000 colony forming unit per ml in 2 consecutive samples in asymptomatic women and in 1 single sample in the asymptomatic men. Usually asymptomatic bacteriuria should not be treated. So asymptomatic bacteriuria treated in the cases, for example, before any urological procedures.
Actually, asymptomatic bacteria is like the protecting factor. So it is the studies recommended that if a patient have asymptomatic bacteria, it actually going to protect it from further UTIs. So treating asymptomatic bacteria lead to frequent episodes of UTI. So it should not be treated even only in proven benefits cases. It should be treated. Otherwise, it should be left as such. So,
in patients subjected to placement of nephrostomy tube or double gestants, asymptomatic bacteriuria is considered a risk factor for infectious complication, so should be treated by prophylactic antibiotics. Treatment of asymptomatic candidiuria is not recommended. So, as per guidelines, the asymptomatic bacteriuria usually not treated in women without risk factors, patient with well-regulated diabetes mellitus, postmenopausal women, elderly institutionalized patients, patient with dysfunctional or reconstructed lower urinary tracts, patients with renal transplant, patient before to the orthoplastic surgeries, and with recurrent urinary tract infections. Asymptomatic bacteriuria should be treated before any urological procedure that breach the mucosa. Or asymptomatic bacteriuria should be treated in pregnant women with short course or single dose antibiotic fosfomycin.
So what we get from that slide, that asymptomatic bacteria should be treated in two cases. First is and the other one is and in pregnant women. These are the only two population in which we should treat asymptomatic bacteria. Continue.
So the question, primary bladder defenses. Option A is low urine pH, B lower urine osmolarity, voiding, or TEM horsepower protein.
This is actually the revision of a previous lectures.
So voiding.
Correct, voiding. Actually, these all are the protective. Primary, the initial is voiding.
So define recurrent UTI. Anyone in 1 year says 3 UTIs per year or 2 UTIs in the last 6 months. Usually extensive routine workup are not recommended in recurrent UTI except in cases of renal calculi, interstitial cystitis, or urothelial cancer. So the factors that are responsible for recurrent UTI are decreased fluid intake, habitual and post-coital delayed voiding, wiping from back to front after defecation, douching and occlusive underwear. These all factors are responsible for recurrent UTI. Actually,
there are limited evidence available that these cause UTIs, but these are the risk factors. So that's why we avoid the things in the patient who is having recurrent UTI, that you should increase your fluid intake. And this is the wiping from back to front is for females. And these are the measures we advise patients if they have recurrent UTI. But there are limited evidence for that.
As per guideline recommendation, diagnose recurrent UTI by the urine culture. Use vaginal estrogen replacement in postmenopausal women to prevent the recurrent UTI. Use immunoactive prophylaxis to reduce the recurrent UTI in all age groups.
This vaginal estrogen replacement is the local estrogen cream ointments which we prescribe to patient in recurrent UTIs, as it helps in restore the vaginal pH and its local flora, which is lactobacillus. So it acts as a protection for UTI. And for amino-active prophylaxis, I think it is not available in Pakistan, but it is the vaccination. For UTI, people do get vaccinated, and it is approved in few European states only. The vaccine MV140 and OM89, these are the vaccines which uses to prevent recurrent UTIs. And again.
Use methenamine hipurate to reduce the recurrent UTI episodes in women without abnormalities of the urinary tract.
Okay, there are other things mentioned as well. First of all, as Abdul Hakim says about methamine hipurate, what is this? And these are things written in the guideline. But हम जब go through करते तो रटा लगा के आ जाते. It is methamine hipurate जो है, it is the urinary antiseptic. It is a forgetting drug actually. Before the antibiotics, this used frequently for UTI. But after antibiotics, it use get decreased. But with the time of in this era, there is increased resistance to antibiotics. So it is now it's also becoming as a and you can see there's a strong recommendation for that. So it is basically a urinary antiseptic. What it does in the urine, it is metabolized into form aldehydes, and that form aldehyde denature the bacterial proteins and kill the bacteria. So in that way, it helps to treat UTIs. And the other thing I mentioned as a cranberry sachets, which we prescribe frequently. So, but they are weak evidence for that. Do you know what cranberry does? Anybody? Anybody? I won't call the name. Yeah, it make the protective lining on the uroepithelium, and it prevent the bacterial adhesions to it. That's how it prevent the UTI. And the other thing which is mentioned over here is D-mannose. There are also weak evidence for that. But what D-mannose do? Anybody heard about it? Okay, what it does, it get attached. It also inhibit the adhesions of bacteria to the uroepithelial cells. But how it help? It attached with the bacterial fimbriae, and fimbriae are the bacterial structure which help them to adherence. So by attaching to that bacterial fimbriae, it prevents the bacterial attachment to the uroepithelial lining, and that in that way it prevents the UTI. And in the last endovasacal, continue.
Use endovasacal instillations of hyaluronic acid or a combination of hyaluronic acid and chondroitin sulfate to prevent recurrent UTIs in patients where less invasive preventive approaches has been unsuccessful.
Any idea about hyaluronic acid and this chondroitin sulfate? Have you heard? Interstitial cystitis, chronic bladder pain syndrome, huh? Yes. So what that does? Actually, the bladder has a lining, every epithelium has a lining of glycosaminoglycan. These are the glycosaminoglycan. And by giving these, we restore the glycosaminoglycan layer of bladder. And this layer helps to protect it against the bacterial invasion, and it restores the permeability of the impermeability of the bladder epithelium. Okay.
Use continuous or post-coital antimicrobial prophylaxis to prevent recurrent UTI when non-antimicrobial interventions have failed. Counsel the patients regarding possible side effects of antimicrobials. And for patients with good compliance, self-administered short-term antimicrobial therapy should be considered.
Prophylaxis के लिए, for prophylaxis, what antibiotic and what dose of these antibiotics can be given? Okay, the doses which we have written in the previous slide is for treatment purposes. But for prophylaxis, as you all know, that we use low doses. So what the guideline recommended, either for continuous prophylaxis, we can use nitrofurantoin, 50 to 100 mg OD, or any other drug. Anyone can tell? Okay. How long? Kitna dose hoga trimethoprim? Okay. 100 mg OD we can use trimethoprim as well. 100 mg OD nitrofurantoin, and we can use fosfomycin as well, which is about. But for fosfomycin we give 3 gram sachet every 10th day. Okay. And in pregnant female we can use cephalosporins 250 OD. These are all the low doses for prolonged antibiotic prophylaxis.
Treatment of uncomplicated UTI. In women, first line antimicrobials are usually fosfomycin, nitrofurantoin. Fosfomycin usually given 3 gram single dose, and nitrofurantoin 50 to 100 mg, usually twice daily for 5 days. An alternative to these antibiotics are cephalosporins, 500 mg twice daily for 3 days. If local resistant pattern for E. coli is less than 20%, then trimethoprim sulfamethoxazole can also be used.
अच्छा, इसमें जो ये nitrofurantoin है, there are different doses written on it, macrocrystal, monohydrate, and what the thing is, the macrocrystal, it has increased frequency because it is because of the macro size of the crystals. It has slow dissolve. It is slowly dissolved and it's slowly absorbed. That's why we have to give it frequently. And in monohydrate, it is it's like the extended release. What monohydrate does, it form a gel-like material in the GI tract, and it slowly release the nitrofurantoin. That's why it has less frequency of administration.
So for men, trimethoprim sulfamethoxazole 160 by 800 twice daily is given for 7 days. Complicated UTI. Treatment of complicated UTI, usually the combination of antimicrobials are given. Amoxicillin or second generation cephalosporin with aminoglycoside. Our third generation cephalosporin is given as empirical treatment for complicated UTI with systemic symptoms. Ciprofloxacin may only be used when local resistance percentage is less than 10%.
Local resistance, how would you know? आपके antibiograms होंगे. Your hospital should have an antibiograms which shows what is the resistance pattern at your hospital right now. हमारा जो इधर का है वो around 2018 का है. The latest I can get. The new one is still on the work. आगे.
Ciprofloxacin can only be used when entire treatment is given orally. Patient do not require hospitalization, and patient has an anaphylaxis for beta-lactam antimicrobials. Do not use ciprofloxacin and other fluoroquinolones when the patient has been used in the last 6 months, and manage any urological abnormality or underlying complicating factors along with the use of antimicrobials. So,
the purpose of giving the complicated and uncomplicated treatment of UTI treatment over here is in the asymptomatic bacteria, if we made the decision to treat either on the basis of the line of complicated or uncomplicated UTI, depending on the risk factors patient has. And in the recurrent UTI, we treated on the line of uncomplicated UTI.
So define catheter-associated UTI. Dr. Zaka, catheter-associated UTI. UTI is occurring in a person whose urinary tract is currently catheterized or has been catheterized within the past 48 hours. Microbial growth of 1000 or more colony-forming unit per ml of one or more bacterial species in a single catheter urine specimen or in a midstream voided urine. As per guideline recommendation, do not carry out routine cultures in asymptomatic catheterized patients, and don't use pyuria or presence of cloudy urine for the catheter associated to label it as a catheter associated UTI. Treat asymptomatic catheter associated UTI according to the recommendation of complicated UTI. Take a urine culture before initiating antimicrobial therapy in catheterized patient in whom catheter has been removed. And don't treat catheter associated asymptomatic bacteriuria. Treat catheter associated asymptomatic bacteriuria before to traumatic any urological procedure. Replace or remove the catheter before starting antimicrobial therapy, and do not apply topical antiseptic or antimicrobial to the catheter, urethra, or meatus. And don't use prophylactic antimicrobials to prevent the catheter-associated UTI. The duration of catheterization should be minimal, and use hydrophilic coated catheter to reduce the UTI. So urosepsis. Define urosepsis.
Okay. The saturation जो है what we see in SOFA score. SOFA score has 6 elements. Tubes,
SOFA respiratory rate होता है उसमें.
Respiratory rate.
Life-threatening organ dysfunction caused by dysregulated host response to infection. For rapid identification, a quick SOFA score was developed. In these, respiratory rate of 22 per minute or greater, altered mentation, and systolic blood pressure 100 or less. Septic shock. Septic shock is defined as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with the greater risk of mortality than with sepsis alone. Patient with septic shock can be clinically identified by a vasopressor requirement to maintain a mean arterial pressure of 65 mm of mercury or greater and serum lactate level greater than 2 millimole per liter, and in the absence of hypovolemia. So the pathophysiology of sepsis, E. coli is the most prevalent microorganism responsible for the urosepsis. Septic shock usually result from the release of vasoactive substances such as bradykinin, prostaglandin, histamine, and catecholamines. Profound tissue hypoxia is a cardinal feature. There are 2 phases of septic shock. Phase 1, initial hyperdynamic state, are also called warm shock. It is characterized by increased cardiac output, decreased peripheral vascular resistance, lower central venous pressure, and warm extremities. Phase 2 is hypodynamic state or cold shock. It is characterized by decreased cardiac output, increased peripheral vascular resistance, cool extremities, fever, leukocytosis, and a profound metabolic acidosis are usual. There are 2 biochemical markers that are raised in the septic shock, procalcitonin, and serum lactate. Normally, procalcitonin is not detectable, and in severe bacterial infection, its level usually rises. But in viral infection or inflammatory conditions, procalcitonin level usually not rise or only moderate increase.
Procalcitonin level greater than 2 nanogram per ml, it's indicating that patient is going into sepsis. But if level is greater than 10 nanogram, then it is an indication of severe sepsis. So the higher the procalcitonin level, the higher the chances of mortality.
Serum lactate. Serum lactate is a marker of organ dysfunction and is associated with the mortality in sepsis. So the question to the audience, the most reliable early clinical indicator of septicemia is option A, chill, B, fever, C, hyperventilation, D, change in the mental status. Prevention of sepsis. Prevent the sepsis, aseptic techniques should be followed, including the routine use of protective disposable gloves, frequent hand disinfection, and use infectious disease control measures to prevent the cross infections. Second, appropriate perioperative antimicrobial prophylaxis, and for nosocomial urosepsis, reduction of the hospital stay, early removal of the catheters, avoidance of unnecessary urethral catheterization, and attention to simply daily aseptic technique to avoid the cross infection. Use of least invasive method to release urinary tract obstruction until the patient is stabilized. Treatment of urosepsis. Treat the patient in collaboration with intensive care and ID specialists. Workup should begin with the history, physical examination, urine analysis, CBC, LFTs, electrolytes, and patients should be pan cultured, including the blood culture, urine culture, and wounds culture should be taken before starting the antibiotic therapy. ABGs and serum lactate dehydrogenase levels should be followed to monitor the patient progress. Imaging investigations such as ultrasound or CT should be performed early, and X-ray test is mandatory, and plain film of the abdomen and IV use may help to identify the source of infection. So as per the guideline recommendations, perform the quick SOFA score to identify the patient with potential sepsis. Take a urine culture and 2 sets of blood culture before starting antimicrobial treatment. Administer parenteral high-dose broad-spectrum antibiotics within the first hour after clinical assumption of sepsis. Adapt initial empirical antimicrobial therapy on the basis of culture results. Initiate the source control, including the removal of foreign bodies, decompression of obstruction, and drainage of abscess in the urinary tract, and provide immediate adequate life support measures. Commonly used antibiotics in sepsis are cephalosporins, penicillin derivatives, usually piperacillin, tazobactam, aminoglycoside, gentamicin, amikacin, and carbapenem, imipenem, and meropenem. These are given usually for 7 to 10 days, and longer courses are appropriate in patients who have slow clinical response. Adjunctive measures, fluid therapy with crystalloids or albumin. If crystalloids are not adequately increasing the blood pressure, passive leg raising induce changes in the cardiac output and in arterial pulse pressure are predictors of fluid responsiveness in adults. Vasopressors such as norepinephrine should be used, and dobutamine is used in myocardial dysfunction. Hydrocortisone should be given only if fluid and vasopressor do not achieve a mean arterial pressure of 65 or more. Blood products should be given to target a hemoglobin level of 7 to 9 gram per deciliter and monitor the patient progress with ABGs and serum lactate. Mechanical ventilation should be applied if indicated. Sedation should be given minimally, and neuromuscular blocking agents should be avoided. Glucose levels should be targeted at 180 or less milligram per deciliter, and DVT prevention should be given with low molecular weight heparin. Stress ulcer prophylaxis should be applied in patient at risk using the PPI, and enteral nutrition should be started within 48 hours.